Good afternoon. It's nice to see so many people here. There were some very vocal young ladies. Can I request you to move forward a little bit, because I think with visual fields we just want to know what it is that you'd like me to highlight. But if you're all in the dark, I can't see you. Can we have some more lights on, please, in the hall? We've had these two lovely talks on intraocular pressure and gonioscopy, and then on the optic nerve head examination. I think I would disagree strongly with Devan when he says that IOP is not a criteria. I think as far as we are concerned, we are lucky that something that's easily measurable like intraocular pressure is seen in almost all the glaucomas we are likely to see. So please, we are not Caucasians, we are not white. We have a different kind of glaucoma that we see, so please understand that intraocular pressure is still one of the most important signs for us in India in the diagnosis of glaucoma. You may occasionally come across normal tension glaucomas, but they're the exception rather than the rule. More than 90% of our glaucomas would have raised intraocular pressure if we actually looked for it. And as was being said in the first talk, do at least 2 or 3 intraocular pressure readings, and if the intraocular pressure, despite your suspicious disc, looks to be about 14 at 10 o'clock in the morning, just try and repeat it again in the evening, or the next day where you come early in the morning, have the intraocular pressure repeated. We now come to a talk on visual fields, and the idea of doing a visual field is to finally confirm whether we actually have a definitive loss of the optic nerve or the ganglion cells, which could be attributable to glaucoma. Again, we know that many things can cause visual field loss, but what we are interested in is to see whether the visual fields that we are looking at are actually affected by glaucoma or not. So just to sort of start off with, one must understand what we are testing when we do any kind of perimetry. We are trying to see what we can see from all directions at a defined moment in time with the patient looking straight ahead. What we actually measure as those lovely numbers that you see is the retinal sensitivity at a particular point. But each number, all that it represents is that the patient was seeing it 50% of the time that it was shown to the patient. So there's actually quite a lot of variability, so don't take numbers as being sacrosanct. If you look at it, you will find that what we actually end up measuring is differential light sensitivity. We have some light in the background above which we are now showing these spots with an increased intensity, and this differential light sensitivity is what is recorded on all our perimeters. The correlation, as you can see over here, the brightest in decibels is probably going to show up there, and the dimmest is going to show up over here. And if we look at what actually happens in glaucoma, and this has been shown to us by Dr. Sood so well, is that the inferior rim tends to get thinner first, followed by thinning of the superior rim. What we have when we see the nerve fibers over here is a crowding both at the superior pole and the inferior pole, with a huge redundancy of the nerve fiber layers. So that if there's one point on the retina that is being subserved, there are actually probably 50 ganglion cells and probably 50 axons which are actually subserving that one point. So you have to lose a large number of ganglion cells and nerve fibers before you start getting any defects at all. And as you can see, the first few defects that you're likely to see are paracentral scotomas and nasal steps. And these are all within a defined area. So when we're talking about glaucoma and glaucomatous optic neuropathy, we are doing perimetry to look specifically at this area, which is called Jerum's area, being how many degrees from fixation? Where are my young ladies? Come in front. Oh. Okay, so Jerum's area is not in the central, not around the fovea or the macula, but it is where these nerve fibers are actually likely to go. So it is 10 degrees to 20 degrees from fixation. And the most common early sign of glaucoma that you're likely to get is going to be a paracentral scotoma or a nasal step. And when these two join together, you're going to end up getting an arcuate scotoma. So a loss of fibers over here probably will reflect in some kind of a scotoma here. Loss of the ganglion cells and fibers there will result in a nasal step. These two will coalesce and then come towards the blind spot. And sometimes at the blind spot you get a small scotoma over there, which we call the sedal scotoma. When you look at any perimeter, whichever machine you have, you're going to actually look at a few numbers just to start off with. You want to know what was the program that was used. All right, so just to start you off, this was a 30-2 threshold test. All right, it was, as you can see, done on a Humphrey field. We are looking to see what kind of strategy was used, and you can see it's a full threshold strategy. You can see that the patient has been adequately refracted and refractive correction has been given. I'm sorry, for some reason or the other the pupil is not there, but you must also note that the pupil should be at least 2.5 millimeters if you want to get a good field. You also want to make sure that the patient is actually looking straight ahead so that you are evaluating his field as we have defined it. And you can see that in this particular patient, this is absolutely reliable. So would somebody tell me how many fixation losses are acceptable before you sort of 20%? And what about fixation false positives and false negatives? Up to 33%. But if you have false negatives in a very advanced glaucoma, up to even 34, 35 or even 40% we are willing to take. But in the false positives, even 33 probably will make you look at the field that you're looking at with a little bit of suspicion. If we go further, you have to decide that now that you've found that it is the right patient, the right strategy has been used, patient has been adequately corrected, the pupil is a good size, what do we look at next? What would you like to look at next? Somebody said a grayscale. Anybody else with any options? Okay. The grayscale, if you look at it, the number of spots that are there, one here and one here, but you look at the number of spots that are put over here, there are about 10 between those two spots. So remember that the grayscale extrapolates and just gives you a very sort of general idea of what's happening, and sometimes this can be completely fallacious. So I personally would feel that you should actually go on to look at the total deviation and the pattern deviation plot after ascertaining that your foveal threshold is similar to what your patient's visual acuity is. As I can see, I've taken a field where we got none of that on. So if we look at total deviation, what is the total deviation showing us? What do we get from these numbers on the total deviation? Sorry? All right, so it's just giving us a very general idea of what's happening. It could be a specific defect, it could be cataract, it could be a myotic pupil, it could be anything. So what are these numbers? Okay, so there are a few perimeters which have normative data. So each age, the age of your patient, they'll have enough age-matched normal controls to be able to say that if this point is 32 and this the age-matched normal was say 33, it will show up as a loss of 1 decibel. And if you look at it, this will not be highlighted, but if you look where the defect actually is, you can see that the patient is having us put a very high intensity light to be able to appreciate it here. And you can see that the loss is probably about minus 30 over there. So that minus 30 is being highlighted in this deviation plot, which has many different degrees. So if you can see that these degrees also tell us what is the likelihood of this being seen in a normal population, you can see that these dense ones are likely to be seen in less than 1% of the normal age-matched controls that this machine has already put inside. We then look at the pattern deviation, and what are these numbers telling us as compared to total deviation? What does the pattern deviation numbers tell us? Deviation from the mean, something else? How does it pick up the localized? Wonderful. So you take the 7th point and you actually say that that is probably likely to be the point at which most of the retina or the retinal sensitivity can be assessed. You minus that and then you come up with numbers which are again being depicted as a plot. So here again you can see that this and this are very similar. So if these are similar, what is it telling you? They're almost exactly the same. What does that tell you? So there is no additional generalized deficit that is seen, and most probably this patient is young. Okay? After having seen this, you can go back and you can look at your representation over here, and you can see that there is a kind of match over there, and you go on to see your glaucoma hemifield test and it says it's outside normal limits. Your MD, everything is being highlighted in this particular printout as being red and unlikely to be seen in a normal age-matched control. So just to go over a few important definitions, what is a scotoma? As defined by Anderson, you have to have at least 3 contiguous points, of which one must be seen in less than 1% of the normal age-matched controls. They should be non-peripheral and should not be in contiguity with the blind spot. Or your corrected pattern standard deviation should be less than 5%, but now because we are all using CETA standard, we don't get a corrected pattern standard deviation, or the glaucoma hemifield test must be abnormal. Having all these, we should be able to reproduce exactly the same defect in at least 2 consecutive fields before we say that this is a scotoma. So coming back to this field, you can say that this is looking as if there's definitely an inferior nasal step, probably the beginning of an arcuate scotoma, but it doesn't seem to have reached the blind spot yet. Is that visible to everybody? Yes? So definitely this is an inferior nasal step, and for the moment we can't call it an arcuate scotoma. We have to reproduce it in another field before we can even say that this is a scotoma. Going back to all the slides that have been shown to us, you can actually see that there is a thinning of the neuroretinal rim over here. And one of the things I like to tell everybody is that sometimes it's difficult to tell where the inside of the optic nerve head or the cup is. So if you look at the blood vessels, you can see where the blood vessels are turning and use that as the point of your assessment for the neuroretinal rim. And you can see that there's a neuroretinal nerve fiber layer loss over there, and you have to have a corresponding visual field defect. So if you have a visual field defect which doesn't correspond clinically with what you can see on the optic nerve head, there's something that is wrong. Either the visual field is wrong, or you haven't assessed the optic nerve head right, or there is, as has been highlighted earlier, maybe a retinal scar, it could be an AION or something else that has caused the visual field defect. This particular patient, as you can see, had high intraocular pressures, which you're likely to see with most of the patients that you are seeing. And if we were to see what kind of field effect this is, would somebody like to comment? How would you actually finally diagnose this? What sort of conclusion would you make with this field? Sorry? So you can see that most of the area above the horizontal raphe has been involved. So this would probably be a hemispheric defect, except that these points are not affected. And if we go back again, you can see that there is some evidence of a retinal nerve fiber layer loss, but it's a high probability that if you look very carefully, you can see a blood vessel which is sclerosed. Can you see this blood vessel that is sclerosed? Yes? Is it visible from there or not? Okay, so the sclerosed blood vessel has caused this, and if you don't have a nasal step, which I said was one of the earliest signs of glaucoma, look for some other reasons for the visual field loss that you can see on perimetry. Would anybody like to read this field for me? I think we'll start with the front. Devin, just turn around and the lady in the corner over there. Yeah, here. This one. एक माइक है अपने पास? हाँ. No volunteers, we'll conscript you from one side to the other, okay? Would anybody like to read this field? I think this is fairly simple. There were days where people hadn't seen a lot of Humphreys. Now everybody sees Humphrey and octopus fields. No? Just hand it to the lady in front. Yeah, the one with the waistcoat. The one with the white waistcoat. Come on. We're just going through.
It's not very clear. Why don't you move up front?
Come a little closer and see.
So it's a central 30-2 field.
Yes.
Of the right eye. It's not very clear. It's 31.5, I think.
Stimulus size 3.
Stimulus size 3, white background is 31.
For a 44-year usability.
Yes. Okay, so you've said that it's a 10-2 Sita standard. The patient has a 6x6 vision about 40, so that's why no correction has been added. Remember that it's done at 33 centimeters, so we need to give a near correction whenever we do a visual field. And what do you see here? Is it a reliable field or is it unreliable?
It's
Fixation losses are 1 out. Okay. And?
6% and 2%, so it's a reliable field.
All right, it's a reliable field. What do you see over here? These are your total deviation plot and pattern deviation plot.
So ma'am, we see some deviation from the normal, so it looks like Siedel's, probably Siedel's scotoma.
Okay, the Siedel's would actually be only in relationship to the blind spot, but you can see that these are the points that are coming down to the horizontal raphe as well. Okay, so again, what we generally say is that the first points to go are the nasal step, but there are patients in whom you can get scotomas which are closer to fixation, and you can see that it is actually outside normal limits. Yes, so it's meeting our criteria. There are 3 points, 3 contiguous points. Yes.
Yes, sir. Yes. 3 contiguous
points which are non-peripheral and significantly depressed.
1%.
Okay,
Yes.
But this is not again meeting our criteria for glaucomatous fields, which generally tend to occur from 10 to 20 degrees from fixation. But we'll keep this in mind. All right, it could also be a normal tension glaucoma, which tends to have field loss, which is very close to fixation.
We should also examine the optic disc before we comment on that.
Absolutely, absolutely. Everything you must always correlate with the optic disc. Thank you.
Before she goes, let's have her bring out some person she doesn't like. You can read the next field.
Just hand it to the next person, I think. Just hand it to the next person. Okay, so again we are looking at these fields. Let's go by and large with the fact that they are reliable fields, but it is essential that you try and interpret them to help you decide, is the patient having glaucoma or not glaucoma, or should we be looking for other defects. So I'm telling you that this is a reliable field.
Yes, ma'am, it's reliable.
Okay, so you can see that there's a defect, again both correlating, total and pattern deviation are correlating. So we are saying there's no cataract, there's nothing else. There is this defect which is reproducible on 2 or 3 fields. Your glaucoma heavy field test is outside normal limits. All these are highlighted to say these are all unlikely to be seen in normal patients. So what is this field defect? How would you describe this?
Superior.
Anybody? Anybody can see a pattern? Sorry? It could be an artifact, so absolutely you could repeat it, but it repeated again, it came exactly the same. So what else could you think of? Does it look like a glaucomatous field defect? No, okay, because I'm saying this repeatedly to you. Paracentrals also occur with the nasal steps. There are no nasal step here, but this seems to be going along the vertical meridian. So think in terms of a neurological problem, or think in terms of a retinal scar or anything else that could have led to this. Okay? Thank you. The next one, please. They can just stand there only and say. The next person. There's a boy in the blue t-shirt. Just read this. I'm just telling you that it's a reliable field. Beyond that, please read what you can see in the field.
Total deviation, we can see diffuse areas of...
okay, so here you can see something before we go further, 30-2, but what was the strategy used?
Theta-fast.
Theta-fast, okay.
Okay, left eye. In pattern deviation, we can see in 3 contiguous points, nasal step. Not nasal step.
So you looked at the total deviation. What did the total deviation plot show you?
It's a there are certain areas of depression all throughout, but in pattern deviation we can see 3 localized points close to the nasal border, left eyes.
Okay.
Close to the nasal border.
So is it a scotoma or is it not a scotoma?
It is a scotoma according to the Anderson's criterion. 3 non-peripheral points. Okay, these are not non-peripheral points.
These are non-peripheral
peripheral points, so it's not a scotoma.
So is there an exception to Anderson's rule? Is there an exception? So when you have nasal step points which are severely depressed, you could consider that an exception, and this could probably be an early nasal step because it seems to be correlating with everything else that is visible plus what was seen on the optic nerve head. But why are you having this difference between the total deviation and the pattern deviation?
Maybe the patient might have cataract.
Yeah, so you can see the patient is on the older side, 60 plus, so therefore you could think that this is probably a cataract. Okay? What about this? Anybody? Pass it on to the next person. So again, I'm saying this is a reliable field, full threshold. What do you think these plots are showing you?
Ma'am, in total deviation, there are areas of general depression, ma'am, and in pattern deviation, we could see non-peripheral points, 3 contiguous points.
Okay, so it's a scotoma. Is it a scotoma?
Yes, ma'am.
Yes. And is it glaucomatous?
It is not. Vertical,
it's actually scattered. You can see some here, some here. So this patient actually had choroiditis. Okay. Pass it to the next person, please. And remember, when you're reading thanks, Devan. Thank you. When you're reading a field, I'm just asking you to sort of become a little bit concise, but you're always going to start by saying, this is the patient, this is the age of the patient, this is the field that was done, and this is the strategy used. That you must start with and then look at the reliability criteria. So who has the mic now? So what was the strategy used?
Full threshold.
A full threshold. So do you know the difference between a full threshold and a theta fast and a theta standard? What are the differences and why do we use them? Sorry?
All points are measured twice in full threshold.
Twice or more than twice? What is it there?
More than twice.
There's a bracketing mechanism using 4, 2 and 2. Alright, so you're going in one direction in series, in steps of 4 decibels, coming down in 2 decibels whenever you find the patient can't see it, and then reversing it again 2 decibels to actually get the final decibels that are written. And what happens in a theta standard? Sorry? Okay, on what basis has this been done? So the machine in the software in the theta standard actually has fields of many kinds of glaucomas, early glaucoma, moderate glaucoma, severe glaucoma, which is beyond what used to happen in the full threshold field. So it already knows that if this point is abnormal, what is the likelihood of the point adjacent to it being abnormal? All right, so that's one thing, that it knows what to do in the next point. So the number of points tested in many directions is much less. What else? What are the other differences between full threshold and theta standard? So, time taken is much less because of this, and also because Absolutely. So it's able to adjust to what the patient is doing. It's interactive, as a lot of you are interacting at the moment. So it decides that this patient is young, is pressing the button early, I can present my stimulus early. It then looks at the adjacent points only if necessary. If it's absolutely necessary, it will go bracket it up and down. Otherwise, it will just present what it thinks is going to be the next sensitivity and move forward. And finally, at the end of the whole process, the patient moves away in a full threshold. That would be the printout that you got. But in a SITA standard, what's actually happening is the post-processing that the machine is doing. So it takes all these points and then says, this point is way away from everything else, so let me smoothen the curve out. So it does a lot of post-processing so that what you get at the end of the day is over a shorter period of time, supposedly as accurate, but there are a few caveats when you use a SITA standard. If you're shifting from full threshold to SITA standard, you must reform a baseline because the SITA standard for some reason gives us much denser and much larger field effects than a full threshold does. So yes, coming back to this patient, what do you think? What kind of defect does this patient have? How would you diagnose or write your final diagnosis of the field?
There's depression in total deviation and a localized defect in pattern deviation.
Okay, so there is some kind of generalized loss.
Yeah, and
it seems to be from the nasal step going all the way up to the blind spot. So this is a arcuate scotoma which has broken through into the periphery, and because these spots are not affected, it's not a hemispheric defect. Okay, in the interest of time, I'm going to move forward a little bit. This is just to say that there's both a superior and an inferior loss that you can see. This is probably a superior arcuate and an inferior arcuate. Hemispheric loss that you can see over here with the early defects seen in the opposite hemisphere. This is a very classical arcuate which is arcing over the macular area. Okay. I'm trying to find one with a... So at the end of the day, each of these must be correlated with what you see clinically and not so importantly with what you can see on the imaging unless you have a problem with the diagnosis. You can have fields which are done on the Goldman, in which case your field effects will look like this. The pattern of progression generally tends to be paracentral to arcuate, and then they both reach the blind spot. And then they break into the periphery and centrally. So what you end up getting is a nasal step, some arcuate scotomas joining together to form an arcuate. And then you can see the breakthrough into the periphery and then finally a breakthrough into the center. So the analysis for progression, these are the printouts that you would likely to see on a Humphrey in this day and age. You will find that two fields have been used to form a baseline. And over a period of time, the visual field index, which is given over here as 89 and 91, you can see has dropped considerably and then has stabilized over here. So what you get is a rate of progression, and it tells you whether that rate of progression is significant or not. And it also tells you what is likely to happen to the patient in the next 5 years. All right? So again, you have a patient like this, and you could just look at the fields and then hope to be able to figure out what's happening. But you can see if you have something like this and it's over the last 10 to 15 years, your GPA or your glaucoma progression analysis puts it down on paper for you, you can see that the patient is absolutely stable. This is another patient in whom you can see that there's a slope going downwards, and in the next 5 years you can see that there's stabilization over here, so hopefully it's not going to progress very much more. On the octopus, it's a very similar kind of printout, or in any other thing. You can have a patient's name, you have the age and everything else that's given over here, including refraction. You have catch trials to tell you whether the patient was looking where he was supposed to look. Again, you have a kind of colored grayscale, and you have the same pattern and total and pattern deviation plots. In addition, you have this so-called Bebe's curve, which is very important because it just gives you some idea of the overall field. There are these two lines at 5% and 95% telling you that this is likely to be a comparison with the age-matched normals, and if there's a red line below, that almost all the points are showing you a depression, and there are about 10 to 20% of points showing you a very significant depression. Okay, this is the same, 5% and 95% probability of being within the normal range, and this one is definitely showing us all points are abnormal. So this is something that we should be aware of when you see an octopus field. It also has a trend analysis and gives us what's happening over time. There's a progressor software that tells us at each point what is happening, whether it's stable or whether there's a significant loss. These are other fields that you might sometimes see. This is an FDT field. This is a matrix field. This is a patient who has open angle glaucoma, as you can see over here. And you're likely to feel that this particular patient is having a lot of problems with his visual field, but there are other fields that can be done, like what's called a binocular Esterman field, and you can see that actually there are very few points that the patient is not seeing, and most of the time he's being able to do whatever he wants to do, and he feels that occasionally parts of the lower field are missing. Another patient you can see has a inferior arcuate scotoma, very scattered defects, all coming up to the nasal step area. And when we did an Esterman field, you could see that the field is absolutely normal when both eyes are being used. The patient actually was upset when we told him that he had glaucoma. Finally, again, please, our aim is always to get, over a period of time, a flat VFI curve like this, saying that the patient is absolutely stable, as compared to this, where you can see that the visual field has dropped considerably. So, just to reiterate once, what is CETA? It's actually using a particular form of statistics, so it already knows what is the probability of the next point being affected. It actually looks at the response time of the patient, and with the CETA standard, the amount of time taken to do a field is almost 50% that of the 30-2 full threshold. There are ways in which you can grade the loss of visual field in glaucoma, and these are by the Hodap-Parrish-Anderson criteria. And I'd just like to say thank you, and thank you for all those who volunteered or were forced into reading the fields. Thank you.